जी डॉक्टर साहब तैयार हैं आप?
Yes, sir.
Please examine the neck of this patient.
Thank you, sir. So Zainab, 25 years of age, female, presented with swelling in front of the neck for the last 6 months. Swelling is in the region of the thyroid fossa on both sides. It moves with swelling. Overlying skin looks normal. There are no scar marks, no pulsations, and no visible veins. Surface of the swelling looks lobular. It measures 8 into 7 centimeter on the right side and 8 into 8 centimeter on the left side. Temperature of the skin overlying the swelling is comparable to the surrounding skin, and it is a non-tender swelling. Margins on the upper and lateral sides of the swelling are well defined, but lower margin is not reachable. Consistency of the swelling is firm. Overlying skin is pinchable. Swelling is slightly mobile in the transverse plane while it is not mobile in the longitudinal plane. On contracting the sternocleidomastoid muscle, there is no change in mobility of the swelling. Trachea is central in position. Percussion note is dull on the upper end of the sternum. Carotids are normally placed. Cocker test is negative. And Pemberton sign is also negative. Eye signs are not present. There are no tremors or no sweating in the hands. Pulse is 80 beats per minute and it is regular in rhythm and normal in volume. Cervical lymph nodes are not palpable. There is no evidence of proximal myopathy, no scalp or spinal tenderness. And heart sounds are also normal. No evidence of pretibial mixed edema, and ankle jerk is also normal. There is no bruit at the upper end of the at the upper pole of the thyroid. On taking a short history, while the examination, patient told that she has palpitations along with menorrhagia and cold intolerance as well. And also she has symptoms of difficulty swallowing and shortness of breath. So that's it.
Okay, thank you. So what's your diagnosis?
Sir, my diagnosis is toxic multinodular goiter, along with symptoms of compression. Along with symptoms of compression.
Long symptoms of compression. Dr. Saab, it says lower edge palpable.
Sir, its lower edge is not palpable.
Then how did you find out that trachea is central?
Sir, I found by the 3-finger method. 2 fingers on the upper end of the sternum and the middle finger on the starting from the thyroid notch.
No, but my question is again same. If the lower edge of the thyroid is not palpable, how you were able to reach the trachea?
Sir, by the auscultation of the trachea.
By auscultation of the trachea, you were able to do the clinical test to find out the trachea is central or not.
Sure.
And your why do you say it is toxic?
See, because she is giving the history of palpitations and menorrhagia, but she is also giving history of cold intolerance that goes in favor of hypo. But since she has palpitations, so I kept it as toxic.
Any clinical sign which is in favor of toxicity?
No, sir. There are no clinical signs in favor of toxicity.
Any important clinical sign of toxic goiter which is not present in this patient?
Sir, tremors in the hands are not present. There is no sweating. There is no eye signs are normal, and there are no tremors in the tongue.
You still think it is toxic?
Yes, sir. Based on the history of palpitations I still want to keep it as
Keep it as
uh,
keep it as what?
multinodular goiter.
So it's a toxic multinodular goiter, what you're saying. Why do
Yeah.
you say it's multinodular?
Because the surface is lobular and on palpation nodules are easily felt on both sides.
So how would you like to investigate the patient?
Sir, I would like to do ultrasound of the neck to confirm my clinical findings and also the thyroid function test to get biochemical evidence of toxicity.
Okay. Any other test?
Sir,
Okay, TSH is also, as you are saying, that TSH is low. So you have confirmed yourself it's a toxic goiter. What will you do?
sir, I will make the patient euthyroid
How?
by giving antithyroid drugs.
Which one?
That is propyl thiuracil
Those.
and for the dose I've forgotten the dose.
And how much milligram tablet of this drug is? What is the name which is available in Pakistan?
5 mg tablet, and I will give 2 tablets in TDS dose. That will become 30 to 40 milligram per day.
Why 30? It's a very high dose, isn't it? How you want
Yes,
to
sir.
start with a high dose? So normally what you do whenever you're giving medicines, you start with a low dose. You never start. For example, if I have an infection and I have to take the whatever medicine is, they're not going to start with 6 grams of this. They're going to start with 1 gram, which is the according to weight the dose is.
Sir,
Okay, you have
I
made it.
don't.
You have made it. You thought it. What you want to do now?
Sir, I would uh, then I will after that I will go for the thyroid scan uh, as well to see the areas of toxicity and the cold nodules as well.
Okay. What else?
And that's it, sir.
Okay.
If
You have done these tests then?
then I will keep the patient for total thyroidectomy, and I will go for baseline investigations and pre-anesthesia workup.
And what two PNC
Because,
workup you will do?
sir,
What PNC workup?
I will do X-ray of the neck and X-ray of the chest as well to see the retrosternal extension of the goiter and other baseline investigations like complete blood counts and liver function tests, renal functions, cardiac function, and coagulation profile.
And your total thyroidectomy you want to do? Okay. How many total thyroidectomies you have done?
Sir, I have assisted. I have assisted, sir.
And you want to do?
Sir, I will take the help, or I will refer to.
And you're in total, how much thyroid you leave behind in total thyroidectomy?
Sir, all the thyroid tissue is removed in total thyroidectomy.
You've done total thyroidectomy, okay. What you will do?
Then I will start with the patient on thyroxine, because the patient is now patient will depend on thyroxine lifelong, and I will also keep the check on calcium levels post-operatively, because of the fear of hypocalcemia, and that's it.
Okay, since the time is in a short case is not more than this, so as usually आपकी time क्योंकि 10 मिनट हो गए तो I'm stopping over here. Let me give you feedback on what you have done. Your history and examination, that is good. If you give so much history, I don't think you'll have a problem in passing. Passing would be there. You said that thyroid fossa. You use this
Sure.
term. Where you have read this anatomical term, thyroid fossa?
Sir, I have listened this term in few short presentations like this one.
Okay. And if you
Not
don't want to
read
use this term, what you're going to say? You're going
swelling
to
on the
swelling on
aspect of that.
exactly. So you can use both things. Now, the only thing which I will, when I was arguing this thing toxic and this thing, the only point which was coming in your mind was palpitation. Rest, there were no signs present. There were no symptoms
No,
present. No
rather
signs.
there
No
was
symptoms.
a of hypotoxicity like cold intolerance.
Exactly.
I-
So therefore, to justify to say toxic multiple goiter, it would be much better if you would say it's a simple multiple goiter, but there is a chance of toxicity that I will keep in mind. Reverse the statement.
right, sir.
You have to think of toxic case in this case.
Sir.
So whether you say toxic and then say there is a good chance it could be simple, that is also correct. Or you say this is a simple goiter, but you can't rule out toxicity because this symptom is present, both are correct.
Sir, how can I put cold intolerance? Because I asked 2 times, she said cold intolerance.
तो ठीक है ना, तो आप क्यों बताते हैं कोल्ड इंटॉलरेंस, तो आप रखें ना उसको, आप क्यों चेंज कर रहे हैं?
So what if he says why you are not keeping hypothyroidism?
Because hypothyroidism के other symptoms they are there. तो आप कह सकते हैं, you can again argue it is similar, but obviously we can't 100% rule out. That is why you're going to go for thyroid test. जिस तरह आप toxicity के argument कर रहे हैं.
Sure.
So this is how the game will go in this case. अगर आप rigid हो जाते हैं, it is toxic, nothing else, then there is a problem. अगर आप rigid हो जाते हैं, simple, then there is a problem.
Sir, actually his biochemical profile was euthyroid, sir. So when I looked upon that,
my first diagnosis never toxic in this case. I don't know the report of this, and that's why I started this question. Because to say toxicity, veins index is there. There has to be many points in that. But if you say multiple, but can't rule out, I agree. Palpitation की वजह से.
Can't rule out, right, sir? Sir, we were told once by seniors that even if you find one symptom of toxicity, then you should think of the toxic solitary or toxic.
Exactly, that is what I am saying. When you're saying you can't rule out, you're thinking about it.
Right, sir.
Otherwise, you
so I would MNG, but I will keep the toxicity in mind and want to rule out by biochemical profile.
Exactly. You can reverse also. You say it's a toxic goiter, but a strong chance it could be simple.
Functions, right.
दोनों तरीके से आप बात कर सकते हैं. Other thing is that when you have committed, you can't see the lower bordal. You can't retrosternal extension lower bordal आपको feel नहीं कर सकते, तो you can't feel the trachea.
Right, sir.
Either you say on the right side lower border is not palpable, or on the left side lower border is not palpable, but if you're committing holes, you can't feel, and the trachea is never in clinical examination determined by ultrasound. by auscultation.
Right. Right, sir.
On auscultation, you cannot comment trachea to be central or deviated.
Right, sir.
That is only by 3-finger method or 1-finger method. Clinically, I'm talking
Right.
about. उस पे आप करते हैं.
Sir, if I can't get lower border on the right side, but I can get lower border on the left side.
हाँ.
I can get border on one side. Then I can feel the trachea.
Obviously, deviated trachea महसूस होगा आपको.
But if on both sides, then I will not mention the trachea in my presentation.
आप फील ही नहीं कर सकेंगे भाई.
Right, sir.
आप देख लीजिएगा ना केस को, क्योंकि वो
Right,
सिर्फ
sir.
ऐसे नहीं होता कि यूं करके दो जा रहे होते हैं, पूरा ट्रेकिया बड़ा होता है. जब थायराइड बड़ा होता है, दोनों लोब सामने भी आ रहे होते हैं, तो आप नहीं फील कर सकते.
Sir, right.
हाँ, बहुत रेयर चांस के वो बात करना शुरू करें वो लखनवी अंदाज में कि हाँ जी लोअर पोल पे एक मॉड्यूल था, वो बड़ा होता गया खिंचता गया, एक वो टुनकना इतना बड़ा बन के नीचे चला गया, तो उसमें तो फिर आप लखनवी अंदाज में तो जो मर्जी कह लें, फिर तो कुछ भी नहीं हो सकता.
Right, sir.
After this thing, then in investigations, if you come to, जो आप बाद में आपने कह लिया बिल्कुल ठीक है, इट्स नॉट एक्सरे चेस्ट अप कराएंगे, बट मोर इंपॉर्टेंट विल बी एक्सरे ऑफ द thoracic inlet.
Right, sir.
X-ray chest from the, and both from the perspective of anesthesia. Thoracic inlet is going to tell you, tracheal deviation is going to tell you resection, and chest is going to tell you about lung.
Right, sir.
If you are committing total thyroidectomy, there is no way somebody is going to excuse you अगर आप serum calcium पैर नहीं कराते तो indirect endoscopy नहीं कराते.
Serum calcium and endoscopy. Right, sir.
If you are committing near total or total thyroidectomy,
Right, sir.
फिर इस पे excuse नहीं करेगा कोई.
Serum calcium and ID. Right,
आप मिस कर गए ना, ये जरूरी. सिमिलरली अगर हम टोटल ये कर रहे हैं और कंसेंट में अगर रिकंडीशनर डैमेज की इन्फॉर्म्ड कंसेंट बाय नेम नहीं लेते कि आपकी हो सकता है ये और कैल्शियम का हो सकता है ये, आई एम टॉकिंग इन्फॉर्म्ड कंसेंट, नॉट जनरलाइज्ड कंसेंट, ये जरूरी हो जाएगी आपकी सब टोटल में. ठीक है, इसमें तो बहुत जरूरी है.
ठीक,
ये चीज आपकी जहन में आनी चाहिए.
right.
Then there was discussion, you went on near total. Then when I saw this thing, for you see the thyroid hormones are present in the blood.
Sure.
For how much time the thyroid hormones remain in the blood before they disappear?
Sir, the half-life is 4 weeks.
4 weeks, whatever it is. So therefore, to give thyroxine, it's not essential to give thyroxine the next post-op day.
Sure.
You will start thyroxine, but you discharge the patient on 4th, 5th day.
Right, sir.
Similarly, if in management you have started propranolol or these medications, you can't stop after thyroidectomy. टॉक्सिक गोइटर है, आपने न्यूमर के साथ प्रोपेनॉल भी लेटर से स्टार्ट की हुई है कार्डियक इफेक्ट्स को ब्लॉक करने के लिए, जिस तरह से पाल्पिटेशन है. थायराइडेक्टमी आपने आज किया तो प्रोपेनॉल अगले दिन उसको स्टॉप नहीं कर सकते क्योंकि सर्कुलेटर कर रहे हैं. So you continue propranolol for 1 to 2 weeks till thyroid कम हो जाए, तब आप स्टॉप करेंगे.
Right, sir.
इस चीज को आप ज़हन में रख लीजिए.
सर ये थायराइड स्कैन और मल्टीनोड्यूलर गोइटर में थायराइड स्कैन की सिग्निफिकेंस ये जरा बता दे, बिकॉज इफ आई एम प्लानिंग फॉर टोटल थायराइडेक्टमी then I don't think so there is like thyroid scan is going to help me in my management. Like if there are cold nodules and hot nodules and so what, I am going for total thyroid.
I agree on that. अगर आपकी मैनेजमेंट है टोटल थायराइडेक्टमी तो उसमें थायराइड स्कैन अगर आप ना भी कराएं तो इट्स गुड. मगर अगर आपका एम है सब टोटल थायराइडेक्टमी तो फिर उसमें जरूरी कराना चाहिए. I agree on that. ये बात आपकी सही है।
सर अगर मतलब मल्टीनोड्यूलर गोइटर है, पेशेंट का लॉन्ग स्टैंडिंग है इन ऑल दैट, और हम लोगों ने देखा कि उसमें कोल्ड नोड्यूल्स भी हैं, थायराइड स्कैन पे हम लोगों ने ये देखा, सो फिर क्या मतलब ये हमें क्या फर्दर वो करेगा कि हम किसकी एफिनिटी, वो तो सर हेटेरोजेनियस सॉर्ट ऑफ होता है ना, कोल्ड नोड्यूल्स भी मल्टीपल होते हैं, हॉट नोड्यूल्स भी होते हैं मल्टीपल, वार्म एरिया भी आ जाता है, तो उसमें
नहीं,
हम क्या
हम कुछ भी नहीं करेंगे, इसलिए मैंने आपसे एग्री किया है इस बात पे कि अगर आपका एम टोटल थायराइडेक्टमी है तो यू मे नॉट डू थायराइड स्कैन।
जी सर,
मैं
जी
आपसे
सर
एग्री कर
बिल्कुल।
रहा हूँ।
और सर थायरोक्सिन जो है वो नेक्स्ट डे ना स्टार्ट करें, 2 वीक्स के बाद स्टार्ट करेंगे,
जी
मल्टीनोड्यूलर गोइटर टॉक्सिक के लिए हम लोगों ने किया है।
जी,
ओके
but even if you start next day, you have not done a major harm to the patient,
जी सर,
but there is no need to start thyroxine on the first post-op day.
ओके सर।
थायराइड फंक्शन टेस्ट अल्ट्रासाउंड के बाद आपने पूछा था और कौन सी, तो वो आप थायराइड स्कैन ही पूछना चाह रहे थे?
मेरे ज़हन में इनके जो ज़हन में था कि
एक से 13 सेकंड है।
जो चीज थी ज़हन में, that was more of a thoracic inlet, क्योंकि इन्होंने ये कमिट किया था, that was first coming in my mind. और बाकी चीज ये है कि थायराइड स्कैन भी ज़हन में था, अगर ये नहीं बताते तो then I would have indirectly asked a question to find out the relationship of thyroid scan के किस किस में कराते हैं, मतलब so then that thing would have come. Discussion में एक दो पॉइंट्स थे कि कॉन्सेप्ट, बेसिकली कॉन्सेप्ट चेक कर रहा होता है, and obviously जब इन्होंने वो कमिट किया अपना टोटल थायराइडेक्टमी, तो जो इन्वेस्टिगेशन है, सीरम कैल्शियम हो गई, इंडायरेक्ट एंजियोस्कोपी हो गई, ये तो मस्ट हो गई, ऑल्दो सब टोटल में भी करानी है आपने, और इस
जी
केस
सर।
में एनी केस ही करानी है सब टोटल भी, क्योंकि आप कह रहे हैं इतना ह्यूज गॉइटर है, रिट्रोस्टेंशन भी हो गई हुई है, तो इट्स अ डिफिकल्ट इवन टोटल थायराइडेक्टमी।
Sure.
सर इसमें डिफरेंशियल्स पूछते हैं एग्जाम में?
डिफरेंशियल्स डिफरेंशियल्स पूछते हैं बिल्कुल। देखिए जब हम डिस्कस कर रहे थे कि और क्या हो सकता है इन दिस केस, so it's a differential diagnosis, it's a simple multinuclear goiter and indifferential diagnosis at a lower end toxic multinuclear goiter, and at a very lower end खैर हाइपोथायराइडिज्म तो होता ही नहीं है हमारे पास, सर्जरी में हाइपोथायराइड कहाँ से आएगा, सर्जरी में केसेस में हाइपोथायराइडिज्म केसेस you are only going to find is after surgery, otherwise hypothyroidism is a disease of medicine, not of surgery. ब्रॉड प्रिंसिपल में आपसे बयान करूंगा।
सर ये अल्सर का जो इन्होंने वो बताया था, कैन आई आस्क क्वेश्चन अबाउट दैट?
श्योर प्लीज मैम।
सर एक तो शॉर्ट केस में मतलब ही सेड 20
अच्छा, व्हाट आई एम डूइंग
years
इज आई एम
में।
स्टॉपिंग द रिकॉर्डिंग नाउ, ताकि वो
जी सर।
दूसरी चीज में कंफ्यूज ना हो जाए, देन यू कैन स्टार्ट द क्वेश्चन, ताकि थायराइड का हमने खत्म कर लिया।